Welcome to Healthcare Quality and Risk Matters. Wondering about patient safety, quality, and risk management, but aren't sure who to ask or we're afraid to ask? Well, you're in the right place. We've created a safe and judgment-free space to explore these critical topics to leave you informed and inspired to make a positive impact on healthcare. So, let's learn and grow together because healthcare matters.
All right. Well, good afternoon, everyone, and thank you for joining us today. Um, you are joining us with what we're calling our LinkedIn Live Healthcare Quality and Risk Matters session in 1 minute. You'll find out more about that in a second. Our goal is to provide everyone information on how healthcare quality and risk can work together to improve patient outcomes. My name is Gary Bierce. I'm the CEO of AparitySoft Healthcare. Joining me today is Rob Santamore. He's our Chief Operating Officer, and also Dr. Timothy Brown, who is our Vice President of Healthcare Solutions. And we're excited to be here today. The format of our show for today is we're going to begin with something we're calling the Incident of the Month, where Rob's going to be discussing a current incident that is relevant to our topic. And our topic for this month is healthcare quality working together and risk management working together. So that's going to be the main topic for today. Then we'll move into a Q&A session. And in that Q&A session, each of us has only 1 minute to answer the question from each other. We'll go around the room and ask different questions about the topic, or it could be about the incident. It could be about anything. But you're also going to get a chance to participate. All you got to do is type in some questions into the chat. We'll be monitoring that and picking those up throughout our show today. And hopefully get those questions answered. So let's get started. Rob, why don't you tell us about the incident of the month?
Good afternoon, everyone. So at AparitySoft HC, we're always trying to stay on top of what is CMS looking at, what are the regulators looking at, and what are they telling our accreditors, DNV, JCAHO, to look at. And in our review, there's online, just a quick Google search of the most prominent fines hospitals are facing right now. There's the CMS pricing transparency rule that came into effect in January of 21. It's hitting hospitals really hard right now. In the last couple months, there's been hospitals all over the country, notably one in Georgia and one in Florida, around the $1 million mark in fines. We believe, in what we've seen with the healthcare organizations that we support, there's a breakdown in the quality compliance risk system that could prevent some of those things from happening and save you $1 million. So compliance is supposed to be your blueprint, right? So they get the information from your accreditor or CMS. And it says, hey, here's your new standard that you have to follow by this date. Who then collaborates with quality, and they collaborate with the process owners to develop processes, education, develop controls around those, how's it going to be measured and maintained, and then also collaborating with risk to close gaps, do gap analysis, risk assessments, and participate in that monitoring program. So when something does go wrong, we're closing those gaps as they come up. And unfortunately, we're seeing that not happen, and we're seeing hospitals hit with almost $1 million fines because we're not complying with new standards and regulations. I found 3 pages now in a quick Google search of different news articles showing these fines that hospitals are being hit with. So if risk, quality, and compliance, we're all working together, in a really cohesive, collaborative, and cyclic way, we might not be seeing those fines, and we might be keeping $1 million in our pocket from the hospital.
So what you're saying, Rob, is that with healthcare quality and the quality department and the risk management department not working together, hospitals are losing money. Is that what you're saying?
They are. They're losing, as evidenced by these fines from CMS, they're losing 7 figures. That's a lot.
Is that every incident, or is that a cumulative situation?
I'd have to dig into each individual one further. There's fines like that, in my experience, come from multiple incidents. One-off incidents don't usually lend you.
Okay.
There's those types of fines. And when you have really strong systems of quality, compliance, and risk, there's those one-offs. There's proof that your system works, right? So you've identified a risk. You're using quality to close those gaps. And compliance is making sure that you have the appropriate blueprint there's necessary to maintain that, right? So when those three aren't working together, you end up with multiple incidents, multiple infractions over time, where you're proving a system failure and ending up with massive fines.
So our incident of the month is basically that an audit came in and discovered where all these disconnects were happening, and it led to fines upon fines upon fines,
Right.
and potentially lost revenue. Is that correct?
A massive amount of lost revenue, which hospitals don't have right now. It's not a great state. Timothy, I see you absolutely agree. There's as a hospital executive, I'm sure this pain hits really hard. The loss of $1 million can really be catastrophic to a hospital.
Well, I mean, any
Absolutely.
business. Yeah, when you hit seven figures, even in public corporations, you're dealing with pennies per share, right? You're starting to chip away at value.
Yeah, absolutely.
That's huge. Yeah.
So designing the correct structure for your organization with these foundational elements of quality and risk is so important.
Well, why don't we transition now into Q&A then, okay? And we'll do our 1 minute Q&A round. Timothy, why don't you be up first? You can ask Rob or me any questions you like, but I'm going to ask you a favor that you could maybe ask a question that would be on our topic of quality and risk and audit not working together, and also this audit that brought this incident of the month. And maybe you can ask Rob a question that can maybe expound upon some of this.
Absolutely. You're boxing me in. I had about 20 questions that I was going to go with. But hey, we'll take that angle for
Sorry
you,
about
Gary. All right. So, Gary, I'll start with you on the area of understanding both risk, compliance, and also quality. What do you think the true benefits are for an enterprise risk management program, maybe versus a reactive or linear risk event response program?
I think you're right on it, right from the beginning. Enterprise risk management is trying to look over the horizon, right? So they're trying to give management a peek into what could happen, what is most probable, and then also tie that back to impact in the organization. That should inform quality programs, right? So rather than waiting for the incident, waiting for the finding from an audit, now you're taking action, corrective action up front on things that have already been identified.
Absolutely.
By doing this, think about the benefits that are going to come to patient quality here and outcomes, where they can have confidence now in that OR, in that ER, because the hospital, which we all assumed was doing this, right, are ahead of the curve. So that's what I see the benefit of ERM.
You're talking about being proactive in healthcare.
Absolutely, proactive. Right?
Absolutely.
We are so reactive.
We are.
So
We
reactive.
definitely are. Unfortunately.
Our system.
All right. Why don't we do this way? We'll do like a tag team, okay? So you got to ask me the question, so then I get to ask the next question.
Sure. How about you take the next one?
Okay.
How about
All
that?
right. Well, I'm not going to pick on you. I'm going to go to Rob.
All right. Perfect.
Rob, why do compliance and quality and risk not work well together in hospitals? Why? Why is it going down that path?
So in the hospitals that we've worked with, there's in our team here, there's over, I would say, the last 10 years, we've seen a lot of movement towards lean process, or value stream processing, where you are designing structured and linear functions with the idea that there's easy management of those service lines and support systems. And it reduces waste. And that is an awesome concept. And I think it applies so well to so many different areas. There's industry. And it does in a way apply to quality, risk, and compliance. But those functions are not linear, right? They're cyclic. And quality relies on risk. Risk relies on quality. They both rely on compliance. And all those combinations thereof. And they're all the same structure of the same function within an organization. So we have, for management purposes and waste elimination purposes, put these things into linear paths. And
I'm going to have to put the gong on you.
Oh, sorry.
You're in for your minute.
And that's going to be a challenge for me, is to keep that to a minute.
Yeah. So your turn, though, Rob. Your turn.
So Timothy, then what is the current perception that administration has, people at your level, right? The C-suites, what perception do they have of quality, compliance, and risk? Are they considered just mandatory expenses that we need, or are they a value add area supporting the hospital?
Honestly, there are mixed perceptions on how quality is taken care of. Of course, if there's a major event that happens in the healthcare system, we'll find the money. I'll just say that much. They'll find the money. And I hate to say it that way, but it has been the way we've always done it, kind of method of how quality is approached. Mm-hmm. In a more proactive healthcare system, yes, quality is integrated into the budget, is integrated into how we look at the overall care for patients. Remember, it should always go back to the patient. When you're dealing with healthcare, I say that to not only leaders that look at that currently as their model, but those that are looking to reshape how to build, how to grow. Everything that you do must go back to the patient. So if you're focusing on quality, that budget should be incorporated already. There should be an understanding of how it should be focused and moved in the overall organization. Did I do a minute?
You did.
Yeah.
All right.
Excellent. Just at your minute.
Excellent job. He's putting us to shame, Rob.
Hey.
Yeah. I anticipated that, though. There's much more concise there.
Yeah. Yes, there is. All right. I guess it's my turn then. We're going to circle around now. So,
absolutely.
All right. I'm not going to pick on you again, Timothy. I'm going to go back. I'm going to go to Rob this time. Okay. So, Rob, I want to know, I think our viewers want to know. So, can you contrast what's going on today versus how it should work? And I'm going to put a sort of follow-on to this. Maybe I'll give you an extra 30 seconds for that, okay, for the follow-on. But the follow-on is why? Right? I keep going back to the why. So if this is how we're doing today, this is how we should do it. And I'm thinking a process. Okay. Why are we not doing it the right way? All right. What's holding us back?
So we're being held back by the implementation, like we were saying before, of some of those processes we put in to make them linear. But change needs to come from the top down, and we need to have a much greater understanding. There's at the executive and board levels of the impact of these functions. I find that the executives, no offense, Timothy, because you do not apply, that doesn't apply to you, but sometimes the executives aren't educated in this space. And one of our goals here is to educate on the needs, right? So if we can get the executive team and the board to understand the importance of quality, risk, and compliance working together to retain our revenue, reduce our cost of poor quality, stop budgeting for so many fines. We have an opportunity for amazing change in the healthcare system, where we are closing the gaps between quality, risk, and compliance. Did I stay in a minute? I think I did.
I think you did.
Yeah,
I can keep going. But
yeah, I think that was good. That was good. Yeah. So who's next? Who's up now? Timothy?
I believe it's my turn to ask the question. So I'm going to ask this and I'll give you both maybe 30 to 45 seconds to answer, because I think it's a question that should be asked. Could you describe the organizational culture that helps support compliance for a healthcare system? So what type of culture is needed for that change or transition to take place? And it kind of goes along to the question that Gary asked you, Rob, but what kind of culture would you expect to see that would
Hey, I can give a 20-second response to that first, Rob.
I know we're both like so excited to answer that
Right.
question.
Go ahead.
And I don't think healthcare is the only place this happens, but what ultimately goes on in this space is we've always done it that way culture, right? So even though they know it's not the best way, it's almost like there's inertia and they can't break inertia. They're struggling to break from a broken wheel to going and replacing the wheel. So that's what I think needs to change. I think management, by speaking through value and that sort of thing, need to start leading the whole organization towards, let's do what we need to do, not be safe in what we've always done.
Absolutely.
Fully agree. And I'm going to take my 30 to 45 seconds to just elaborate on that from the quality perspective. And the systems that I found most effective, were ones that had high numbers of reported incidents.
Mm-hmm.
There's high numbers of quality improvement events. So a culture of change. So very much what Gary's saying. I'm trying not to repeat what he's saying. I just agree so much that it's dead on, right? You need that culture of growth and change. So if you are a successful system, you are a system that reports every little incident. You are a system that does a lot of high impact audits. You are a system that is not afraid to update your policy in February, even though you just updated it in January.
That's good.
You are a system that constantly engages your education team to be educating on new standards that are directed by compliance and incidents that are found by risk.
Mm-hmm.
There's needs that are found by quality. There's a system of continuous change, continuous improvement, and wanting to do it different today than we did yesterday, completely opposite of some of the culture today.
Absolutely.
Well said.
That's amazing. Yeah.
Well said.
Is
Rob,
it
I
my
think
turn
it's
to
your
ask a question?
turn. I think it's your turn.
Rob.
Did I freeze?
You answered it well. Absolutely.
I think I froze for a second. And so my question is there's Gary.
Ooh, okay.
Gary, you have extensive experience in quality and risk across lots of industries, not just healthcare.
Mm-hmm.
Can you tell me, are there other industries that budget for the cost of poor quality like healthcare does?
I'll be honest, unless you're in the energy industry, potentially, banks, or very advanced enterprise risk management organizations, it's hard to find. Very large manufacturers do, but it's going to be very much down at the ground level, right? So they're looking at errors in manufacturing and that sort of thing. But there is best practice out there, and it's been around for a while. And what shocks me from getting more and more familiar with healthcare is that you would think, because human lives are involved, that they would be at the tip of the spear, not be a lagger in this type of thing. Mm-hmm. So, that to me is something that we've got to change, right? We've got to bring these best practices forward and start getting hospitals that can lead the charge, right? And really start demonstrating how it can make a difference. That's why. Did I stay within my minute?
You absolutely did.
You did, yes.
Perfect.
Did I answer the question, Rob?
You did, actually. I was really curious as to why hospitals budget so much for poor quality. And why we're so far behind other industries when it comes to implementing there's controls, mechanisms, and support systems to make sure that we're not having to put so much of our revenue aside
Well, can I? It's my turn to ask a question, right?
Yeah.
So let's continue on that topic. I have found it very the idea of budgeting, right, for poor quality, in that we're budgeting for problems that we are anticipating will occur, but we're not really getting ahead of the curve to reduce the number, right? It's as though we are accepting it as that's just the way it is. And I've given you the analogy before that it's kind of like, I like to drive fast.
Mhm.
So I'm getting lots of speeding tickets. Rather than slowing down so I don't get speeding tickets, I'm just going to budget for speeding
Like
tickets.
for speeding tickets.
Right. That's sort of what it seems like. Why do you think that the healthcare industry has settled into that culture, Rob? Why do you think? And Timothy, please weigh in on this.
I will jump in. Rob, you go first, and I'll jump in after that.
So I think it goes back to what we were saying earlier about hospitals are not a culture of change.
Mhm.
Hospitals are a culture of Band-Aids, right? We like Band-Aids.
Correct.
And Band-Aids are not long-term solutions. Band-Aids literally just cover the wound. The wound can still fester. And you're going to be left with a pretty significant scar. But if we were able to, add those structures and design, we wouldn't have to do that. We wouldn't have to put those Band-Aids on, and we wouldn't have all of those. I'm trying not to elaborate too far because I feel like I'm going to be repetitive in what we've already said, but I do believe the majority of the issue lies with our inability to grow and our inability to change. And part of that comes from the executive and board level not putting the level of importance on risk and quality as I feel like they need in order to facilitate that change, because that's what quality does, right? They facilitate growth, they facilitate change.
Rob, you took the words out of my mouth with not wanting to change, not understanding the purpose of change for leaders, and really it comes down to we're going to repeat ourselves from what we said earlier, but it's something that you said earlier about understanding and having the knowledge, the information to make those changes. Leaders see reports every day. I mean, you'll get a report on any type of incident that may happen in the organization. Sometimes it's not that they don't know that these things are going on. Sometimes it's just the importance behind it. If you're not pushing that as, we need to make this change, this is something that could help save. They need to see that big picture sometimes. So in change, there needs to be some type of plan and understanding for how does better look? What would better look like for the organization? In that same aspect of creating better, what about the plan to get us from where we currently are to get us to that next step? Sometimes those steps are missing, and it causes a lot of friction and leads us to say, well, we'll just do it the same way we've always done it.
I love that. And can it be my turn to ask a question? Because I have a question that applies to that. And I'm not even waiting for a response. I'm just going. So the most successful hospitals I've worked with in the past were hospitals that included, there's my team in the strategic planning for the hospital. Or quality and risk collaborated and did the strategic planning for the hospital. There's, Timothy, in your experience when developing a hospital strategic plan, what roles traditionally and more often does the quality and risk departments play in the development of that plan?
Ooh.
I hate to have to say it this way. Sometimes they play a secondary role when they should play a starring role. What I mean by that is it's almost to the point where we know quality is important. However, let's build a plan, then we'll bring quality in to add in their overall pieces. Whereas the structure should be, quality should be at the table. The quality team should be at the table to understand how we're moving forward, because you are able to identify where are our pain points, what are our hot spots, what are the areas that we really need to work on for our organization to bring about positive change and to overall save money. That's not every organization I've worked in. I'll be honest. There have been some where quality was not at the table and they needed to be. So does that answer the question that you're going with, Rob?
It does. So it was almost a trick question because I know that unfortunately they don't involve quality and risk as often as they should.
Absolutely.
So,
You knew the answer already.
He knew. I figured he did.
But I like to hear the perspective of the hospital executives too, right? There's knowing that that is recognized amongst you.
Can I opine on this
Yeah.
from an ERM perspective? Because
Sure.
I will tell you that this is classically the problem in every industry, right? If they really understood what risk, quality, and compliance are doing for them, right? And I'll be honest, guys, I believe all of this is an umbrella ERM view of an organization, right? How does risk affect performance, right? Isn't that what we're talking about? How does risk affect achievement of objectives? So if that's the case, quality is a subset of that, right? Pure risk management's a subset of that, and compliance is a subset of that, right? We're all trying to drive towards higher performance. In a hospital, it all starts with the patient. Correct. And it's amazing how those dots are just not getting connected in not just healthcare, but in all organizations. How important it is to have that new lens, right? It's like having a new light on what's going on so you make better decisions. That's the whole concept here, you know? So yeah, I couldn't wait to answer that.
I completely agree. There's with you, Gary. There's quality compliance that risk. They're the same thing. They're all the same. They're all different functions of the same beast, right?
Mm-hmm.
Yeah.
That's absolutely right.
Exactly right.
And back to what we were saying at the beginning of those functions being siloed or linear, and leaving a physical gap between the different functions. And then not recognizing the importance of that. That's why hospitals are facing these $1 million fines.
You're absolutely right.
And we, as a healthcare facility, healthcare organization, preach setting up their people-proof processes, right? That is always our goal. But people execute these processes, right? So there's no way to make anything people-proof. What we can do is add enough structure, give them enough information and the right tools. So that they know how to make the right decisions. There's where to access that information. And when we have disparate foundational elements, people don't know where to look. People don't know who to talk to. And those elements aren't there supporting like they should be.
Guys, we're about 2.5 minutes out. So are there any questions from our audience that we can answer?
I'm pulling up the comment section right now. And Dr. Timothy, you're getting a lot of hellos.
Hey, everyone.
And thank you everybody for joining. And are there any questions, comments?
I have, in the last 2 minutes, I have one last question for both you guys, okay? Looking at systems that are supposed to be supporting all of this, would you say they are integrated or disparate? How would you guys answer that?
Easily disparate.
Easily disparate. Yeah, absolutely.
Easily disparate.
Can you guys elaborate on what you're seeing out there? What are these systems? Why is this making it a problem to do the job and do it right?
So I think it speaks to the efforts that hospitals have made over the last 20 years. There's to do quality, risk, and compliance, right? So when they knew that they needed something to manage their policies and procedures, they bought document control. When they needed something to manage auditing, they bought an auditing software. When they needed something to manage incidents, they bought incidents. And I could keep going, right? There's many, many different elements.
And good or bad, they're doing those things, but and many times maybe not the best thing, but they're not talking to one another.
Correct.
No, so now you
it's
have
the silo.
Yep. So now you have not only you have siloed departments, but then you have siloed tools. There's supporting those siloed departments, right? So
Which
now
just
we went through
compounds the problem. It compounds the
so we
problem.
have so many gaps, and we have $1 million fines.
Correct. Absolutely. Unfortunately. I mean, Rob, you said it all. All I will add to it is understanding that if these individual systems are not talking to each other, neither are the employees talking to each other. I mean, it's a train wreck waiting to happen. So, I mean, we've seen, as Rob has said, these are $1 million fines, and that's just one incident that we're looking at. We're talking about potentially 30 plus million.
We at Carahsoft Healthcare are trying to fix that.
Absolutely.
We have two questions. I'm so sorry. In the comment section, so what would we propose to encourage inclusion with quality leaders at the table?
Timothy, why don't you answer that one?
I'll answer that for
quality
sure.
Leaders to the table.
It takes a conversation with information, and that I know that's a rhyme, but it really does. It takes a conversation, bringing the information to the forefront. Now, quality needs to be included in all conversations that are leading to growth of the organization. It also needs to be included in those areas where we're looking at risk management and compliance as well. If you don't have that quality person, that quality team, or a representative at the table for your meetings of growth, I caution you that if you're not including that voice at the table, you're definitely going to have some risk later on down the road. So it's a conversation with the necessary information.
I fully agree. And I've also seen it really effective to bring a thorough cost of poor quality assessment, which is a comprehensive audit of your organization, and that cost value, I promise, will be 6-7 figures minimum.
Correct.
And bringing that to the table, bringing that to the executive team can help understand the impact that you as a quality leader have on the organization. And we have another question. Dr. Brown, if your organization is aware that quality is taking a back seat when they should be in the forefront, what are you willing to do to help navigate that change?
This is one of those places where you have to step out and just speak up. And speak up to the right people. With that, as I said earlier, the information is necessary. The audit that Rob spoke of is a great way. I mean, executives, we love numbers. So if you could give me that quantitative information that shows that we could potentially save dollars, millions, hundreds, however, for the size of your organization, we're going to listen to that versus you coming to complain with the issue. Bring solutions as well. What solutions do you have? Thoughts that you believe, because I'm a believer that you can't just bring a problem to a leader without a solution. It doesn't necessarily have to be the full-on right solution, but it shows that that initiative that you're trying to solve the problem as you're moving forward.
That's awesome. Dr. Timothy, that's worked for me in the past too, as a quality leader, walking in and finding an executive that understands the impact and getting their support, teaming up with them, and receiving that guidance that you just gave us, right? And then me going back, producing that information, bringing it back to you, and then collaborating to bring me to the table.
You guys heard me talk about the language of the C-suite, right? So the language of the C-suite is dollars and cents.
Dollars and cents.
So you need to be able to bring a thorough cost-benefit analysis forward that can be substantiated, right? You need to bring the compelling argument, so to speak. With that, they're going to listen, right?
They will.
And don't get caught in the weeds. Get into the big value that's coming out of the solution. That's the other thing.
There's folks, we are at time. Gary, do you have any last minute words of wisdom?
Well, no, I think I just want to thank everybody for joining us today. We're looking forward to doing this every month. So I'll be looking for our LinkedIn posts announcing the next one. Rob, is it right at the third Thursday of every month, correct?
I think it's the fourth now. I think.
Okay. Starting next month, it'll be the fourth.
Starting next month, it'll be the fourth. Yep.
It'll be the same time every month. And we're looking, and then right now it's the Wednesday, right? We're on Wednesdays. Is it going to be Wednesdays or Thursdays?
Wednesdays, I believe.
Wednesday. It'll be on Wednesdays. Okay. So everybody, thank you. We really appreciate your questions out there, and continue to join us and support what we're trying to do here. Let's see if together we can improve healthcare quality and patient outcomes.